Tony. Thank you for that wonderful introduction. I hope I can live up to this. Good afternoon, everyone, and thank you all for joining us at our 11th State of Hope programs. It's hard to believe. We started this a few years back, and it's really grown. The State of Hope was originally created to provide an opportunity for the community to convene to discuss contemporary issues in healthcare and the impact that they have on current and future policy. And this evening's event will focus on bridging the disparities gap with DSRIP 2.0, the integration of health and social care. Now, as many of you know, the Delivery System Reform Incentive Payment, or DSRIP program, was initiated to promote community-level collaborations and focus on system reform, specifically with the goal to achieve a 25% reduction in hospital use over 5 years. And in April 2015, New York State received an initial investment of $8 billion, which was really provided many successful programs and initiatives. Unfortunately, as of March 31st, 2020, DSRIP funds were not extended and the program stopped. This summer, New York State Department of Health submitted a concept paper to the Centers for Medicare and Medicaid Services requesting additional funds to continue DSRIP. And the key takeaways from the state's request include a focus on promoting health equity, continued commitment to value-based payment in Medicaid, recognition of the successful results of the New York DSRIP program, and the continued efforts to invest in and expand strategies to devote to the social determinants of health. Even the slight prospect of DSRIP's return is exciting and has the potential for positive health and social impact on communities across New York State and can truly benefit those in communities that are most in need. And our panel of speakers today have all had firsthand experience with DSRIP programs, and they're all advocates and leaders in the field. I am so looking forward to hearing the discussion and would like to thank our speakers who have been so generous to share their experience, their insight, and their expertise. And to facilitate the discussion this evening, we are fortunate to have HPHF Health Policy Fellow, the Honorable Kemp Hannon. And Kemp joined HPHS in April 2019 after the distinguished career in the New York State Senate, where he built a reputation for working across party lines to put the health and well-being of others in the forefront. He continues to do that by organizing and facilitating our State of Hope programs, which allows for an exchange of thought, policy, and practice. It's my pleasure to turn the program over to Kemp.
Thank you very much, Dean Sarah. Good day. This is a very exciting forum that we're going to be having today, discussing what's called DSRIP, the whole program that comes from the allowance by the federal government to modify how the Medicaid system in New York State is run. Now, the Medicaid system, to many people, it's not necessarily something in the forefront of their policy imagination. However, there are over 7 million New Yorkers on Medicaid as we speak, 7.2 million to be exact. And any changes in how healthcare is delivered through Medicaid not only will affect those 7 million, but every other person receiving healthcare in the state. We're coming out of the pandemic. It's December 2021. We are going to be talking about an application by the state to the federal government. The actual application hasn't been made yet, but a conceptual application has been made. And those concepts are extraordinarily important. We have a live link to those concepts in the background material. And I heartily recommend, it may be a little tough going, but reading that conceptual application to get a better understanding. One of the core concepts that comes out of it is, what do we need to do going forward with New York State's healthcare? So far we have, and throughout the pandemic, we had a sense of patients presenting to hospitals or to clinics or to a doctor when care is needed, and the provider responding to that care. However, studies have shown, and reliably shown, that social determinants of health factors have, rather than medical interventions and services, are a key driver for a majority of health outcomes, up to 80%. In other words, if you just try to deal with healthcare by taking those who present to a healthcare provider, you're not going to be successful. DSRIP 1, which was done about 10 years ago, was a $7 billion program, very elaborate, had 25 organizations throughout the state called preferred provider organizations and had different measurements of success. We're going to hear from two gentlemen who headed two separate of the PPSs during that period. The actual experience will be mighty. Before we get to that, we want to deal with what Professor Markowitz, a professor at Hofstra, where he is an assistant professor who has vast experience in administration of healthcare, direct in the county with healthcare systems, and has been teaching healthcare at Hofstra for several years, will lay out some of the principles that we are going to be discussing. Will then be followed by Professor Renee Mcleod in regard to especially her focus on population health. Then we'll hear from David Nemiroff, who currently heads the FQHC of Long Island, the Federally Qualified Health System of Long Island. And he headed during the DSRIP 1, the NASA DSRIP, the NASA PPS part of DSRIP. And finally, Joe Conte, who headed the Staten Island PPS, will finish off. So to start off with, Professor Markowitz, the podium is yours.
Thank you very much. What I tell my students all the time is that you need to have a conceptual framework. And from that conceptual framework, you need to apply that to what reality is. I wanted to start off with some, we'll call them definitions / descriptions of health disparities and also who are the vulnerable groups. And the first slide, Tony, can you just push that slide down, please? Comes from Healthy People 2020, where they are describing health and healthcare disparities. And as it says here, and following up on what Kemp has just said, is that they're closely linked to social, economic, and or environmental disadvantage. And then there was a listing that Healthy People put together of who falls into this category. And we have race or ethnic groups, religion, socioeconomic status, age, and it goes on to sexual orientation and gender identity, even geography. And then there's the famous or other characteristics historically linked to discrimination or exclusion. Just by example, just yesterday, one of my students did a presentation on disparities. No, I didn't pay her to do that. And she kind of rattled off a series of disparities with regard to the African-American community that were very telling. And it related to first life expectancy, infant mortality, cancer mortality, lower rates of health screenings, hospitalizations and rehospitalizations. And then the one that kind of shook me a little bit is that we also see that African Americans and Latinos use mental health and substance abuse services far less than does the white population. In addition, what she kind of shared was that, and kind of what we've been reading, is that the African American community also has higher rates of both COVID infections and also COVID deaths. Next, please. From AHRQ, which is the Agency for Healthcare Research and Quality, they put together a listing of what they call priority populations. And this was the first cut at this. So, and again, you'll see some similarities, obviously. You have low-income populations, racial and ethnic minorities. They included women. And I was a little bit surprised because I had not seen prior to this children and adolescents listed as a priority group. And at the same time, I've been very cognizant of the fact of a lack of mental health services for children. The elderly as a group, my very first job was as a nursing home administrator, and certainly sensitized me to the needs of the elderly and then individuals with special needs. Next slide, please. AHRQ then added an expanded list, which was kind of interesting, which included some of what you saw before, which included religious minorities, lesbian, gay, bisexual, transgender, and queer communities, people with disabilities, rural areas, and then this category of persons otherwise adversely affected by persistent poverty or inequality. I wanted to add one of my own. Actually, I wanted to add two of my own. One is very much related to what we saw in the DSRIP proposal, which are people who've been released from prison, a majority of which have either mental illness and or substance use disorders. And as a general category, we obviously have seen what I would call discrimination against people with a mental illness and or substance use disorders, and things such as lack of appropriate health insurance, and also tremendous lack of manpower resources and facilities resources to care for these populations, either those who are severely affected or those that even have mild disease. Next slide, please. This is a slide which was of interest to me because the original diagram did not have the bar going across for racism and discrimination. And what it lays out is, well, and again, initially it was called social determinants of health, and now they've changed it to health disparities that are driven by social and economic inequalities. And the major categories, major columns that you see are economics, neighborhood and the physical environment, education, food, community safety, and social context. And I don't think that we've really paid enough attention to that. And then obviously the healthcare system. And then the disparities are related to the items that flow down from the bottom. I wanted to give a very quick story that Kemp might remember. We had a health commissioner in New York State by the name of David Axelrod. And David conducted a meeting here in Suffolk County of health executives. And at the breakfast, after everybody ate, he put this little smirk on his face and said, "Well, fellas, here's why I brought you together. We've just done a study here in the state of New York, and we have determined that there is virtually no cardiac disease among the African-American community." We thought that he'd lost his mind. He says, "Well, let me tell you how we actually came up with this." He said, what the study was is that we did a study of all open heart surgery that was done here in the state of New York, and only 3% of all open heart surgery done in the state of New York were done for those who are African Americans. And that was where I first started to have a real serious understanding about the impact that race and discrimination have relative to our healthcare system. Next slide, please. I put together, I'll call it the Walter model for an effective healthcare system. And the first page actually has very common material, and the second page has something that's a little bit different. So we speak about accessibility or availability, and I've always used 3 parameters of that. The first is financial. Can I afford the care? Second is temporal. Can I get the care when I need the care? So about 4 weeks ago, I decided I needed my annual physical, and I can't get my annual physical until the end of January. And I have a lot of pull. So I kept on thinking about all of those people who can't get care. And then when we speak about financial and temporal, I also thought about the famous question that seems to get asked all the time when you call for an appointment. And the first question is, what is it? So the first question is, what insurance do you have? Mm-hmm. And that first question of what insurance do you have is even omnipresent with physicians who are employed by not-for-profit networks, where somewhere in their mission, vision, and value statements, it says something like, We will take care of everyone without regard to ability to pay. Well, if that's the case, why is the first question not what seems to be the reason that you need an appointment, as opposed to what insurance do you have? And then, can I get there? Geographic transportation. When I ran the clinics at LIJ, you needed 3 buses if you came from Southeast Queens in order to get onto the campus. We then have continuous and comprehensive, and what I've always liked to give as a perspective of that is, according to who am I getting comprehensive care? Is it comprehensive according to the insurer? Is it comprehensive according to the patient? Or is it comprehensive with regard to the provider? And those 3 are not always the same, and in fact are frequently not the same. One of the things that I'm sure that David and Joe will be speaking about is the concept of coordination, and how we really do need to coordinate care. And that's really linked to the last bullet, which is you really have to have an effective information system that can increase efficiency and coordination. Then we have high and equal quality of care. And I included 2 parameters. One is process and the other is outcome. Are we doing the right things for the right reasons? And are we getting good outcomes for our patients? And again, each of those have different consequences for organizations, such as patient-centered medical homes, for accountable care organizations, and also for value-based payment systems. We certainly like to think that the care that is going to be provided is evidence-based and certainly patient-satisfying. Patients who are satisfied are much more likely to join in a partnership with their physician in order to comply with care plans. And then, of course, I put cost near last instead of putting it up first, which unfortunately seems to be the driving force for so much of our care system. Next slide, please. So now I added a bunch of other things, which some may be self-evident, maybe some are not so self-evident. For some reason, we still haven't really figured out a good way to make prevention and wellness work. I don't know how else to put it, but somehow or other, we seem to have a healthcare system that is a lot more interested in taking care of sick people, which it surely should, as opposed to preventing illness, of managing population health, of really having a wellness improvement. Why is it that you get paid so much money, more money when you take care of a sick person as opposed to prevention and wellness? And then added to that, obviously, is screening and early detection of disease. People of my generation have chronic illnesses, conditions, and as we get older, we seem to have more of them. And to the extent that we can manage these effectively, will keep us out of the hospital, will keep us out of the emergency room. This is going to require an excellent primary care system, and considering only about 25+% of all physicians are not, are primary care and 75% are not, we have a real disconnect about what the needs of various populations are in this country. We really do need to integrate both health and behavioral health services. Something that is part of NCQA PCMH certification. And quite frankly, we haven't done a good job with this. And then I added these last 3. We really need to develop care plans and how we're going to manage patients, inclusive of all of the social determinant considerations that I mentioned. And then the last 2. And I put in one system for all, and I had a number of different views about this. And I wanted to first speak about some of the wisdom from my old CEO at Southside, Mr. Josby, who passed away a couple of years ago. And Ted gave a talk once that went something like this. He said, you know, we have a very odd healthcare system. He said, if I have patients who are under a per diem system, I want to bring in as many patients as I possibly can, and I want to keep them in the hospital as long as I possibly can. And if I have patients who are under a DRG system, I want to bring in as many patients as I possibly can, and I want to throw them out of the hospital as quickly as I can. And if I'm under a capitated system, I never want to see a patient come into my hospital at all. David, yes, you're laughing because you know that this is true. Some of the other things about one system and fair and equitable reimbursement. So imagine that you are a provider under a fee-for-service system. You will make the most amount of money when you see the most amount of patients and you do the most amount of stuff for those patients.
And Walter,
yes,
Walter, let's wind that up right there because that's a great transition point to an excellent opening.
That'll be great.
Okay.
Thank you very much.
Thank you very much. That was wonderful. Next on board is Professor Renee Mcleod, who is a professor at the assistant clinical professor at the Zucker School of Medicine. She's also a director of medical ethics at Northwell Health, and she is a doctor of nurse practitioners. I might get that title wrong, and a professor teaching at Hofstra with an incredible array of different topics. The one immediate value to ask a comment is something that was mentioned in Professor Markowitz talk, which is population health, and which gives rise to the need to widen our scope in this whole waiver from individual care to more of a system-wide care. Professor Renee.
Thank you so much, Honorable Kemp Hannon. And thank you, Dean Syrup, for allowing me to speak. And it's always a tough act to follow, following Dr. Markowitz. And what he was getting at is, how do we get paid? But I want to take us back a little bit to talk about what we're talking about in terms of the $17 billion ask. And I want to talk about heroes. So I really want to thank all of the frontline heroes, which are all New Yorkers and all of us around this country. And I don't believe it's an accident that we saw the largest pandemic at the same time that we had the largest systemic racism demonstrations across this country, highlighting the structural inequalities. And it's really in thinking about heroes or these health equity regional organizations that I want to speak to you. And I want to speak to you from personal experience of when we had the first demonstrations prior to DSRIP, which was the idea of having RIOs, or Regional Health Information and Organization Systems. So as Kemp Hannon told you, I'm a nurse practitioner. I'm a family nurse practitioner, and I've been a family nurse practitioner for 30 years. And as nurse practitioners, we work with the most vulnerable that Dr. Markowitz talked about, the most underserved. And in New York City, the idea of partnering a nurse practitioner with physicians was to improve value-based care by decreasing costs. Could we get cost effective? And could we reach out to touch patients in ways that weren't their medical diagnosis, but how did they get their prescriptions? How did they interact with the world? In other words, the social determinants. So we know that the social determinants are responsible for 80% of our healthcare problems. Why? Dr. Markowitz said there are no African Americans with cardiac disease, but there are plenty of African Americans with economic concerns that lead them not to have more stress, that lead them not to be able to be financially supported. So as we think about COVID, we're thinking about the long haul syndrome. We've seen this in our own area at Hofstra and Uniondale and all of the surrounding federally qualified health centers that my colleague, Dr. Nemiroff, is going to speak about, that the time that it is going to take for communities to rebuild their economic structure is going to be for the next 50 years. And without economics, there is no housing. Without housing, there is no electricity. Without electricity, how do we use the technology that we are proposing on using? And so the proposal calls for these heroes to work in concert with social determinant health networks so that we can have grants and proposals to address social and structural inequalities. Because make no mistake about it, healthcare for all, as Dr. Markowitz talks about, requires social determinants for all. And so we've seen this play out, that COVID made no mistake about our gender, about our sexual orientation, about our race. However, the response that healthcare systems were able to have to COVID was totally determined by economics. Now, I am very privileged to have been a nurse practitioner in Northwell Health with Mr. Michael Dallin, who provided services regardless of all patients. Northwell Health was responsible for over 200,000 COVID-related visits in the first surge. How were we able to do that? We were able to do that by having a coordinated response across regions of 23 hospitals. This is calling for us to have a coordinated response, but a coordinated response to what? Infusing money to deal with diagnosis we know does not work. DSRIP 1 taught us that we had to have a population-based approach to value-based care. In other words, as Dr. Markowitz was saying, not seeing more patients, but actually doing more for patients. And what I'm really thrilled about is that we are finally talking about the things that people need. And I'm really encouraged by Governor Hochul saying, yes, we need to put money into communities so that they don't lose their homes, that they have mortgages. We need to put money into people, into their pharmacies, so that their pharmacies are open at night. We need to have transportation infrastructure so that people can get to their pharmacies. So before I turn this over to my colleagues, I'm going to tell you a little story, and I'm going to be forever grateful to the 4,000 patients that I had in the Bronx in a little demonstration program called a Medicaid Managed Care Program. On Fridays, for children, we had SAT preps. On Thursday, we did salsa dancing with the Hispanic communities and taught them how to have better food. On Wednesdays, we put everybody together in group visits to talk about their diabetes. And what were we told? This is never going to work because you're not seeing 45 patients a day and giving them their prescriptions. Well, I'm proud to say that I've met 7 of my children from 18 years ago. They're doctors, they're lawyers. One happens to even be an IT worker in Northwell Health. And what did we do? We improved their economic function. And by improving their economic functions, they were able to tell me how grandma is 89 years old. And guess what? She has better care now because she has better access now. We have to move from treating disease. We have to improve the health of the population by addressing structural inequalities and creating access. So thank you for allowing me to share with you all of those stories. And if any of my Bronx colleagues are out there, thank you for what we did in the Bronx Healthcare Network with the Rios, because without the Rios, there could not be heroes. So Kemp?
Thank you, Professor McLeod. Really well done. Next, I'm going to ask that David Nemiroff speak, and he has some slides. The slides reflect what an FQHC is. And I wasn't going to do this thinking we just continue to talk about the waiver. But as I was preparing and speaking with people in the community about things that had to happen, I mentioned, oh, and Mr. Nemiroff runs an FQHC. And they go, what's an FQHC? And it struck me with horror because FQHCs are an essential part of healthcare in Nassau, in Suffolk, in the entire metropolitan region. So David, start off with that, and then maybe you can reflect a little bit about your experience heading the Nassau PPS for DSRIP 1.
Terrific. Yeah, we have some slides, and I'll just go through some of them quickly when Tony pulls them up. But again, Dean Syrup, thank you. Senator Hannon, thank you. To my colleagues on the panel, thank you for allowing me to share this panel with smarter people than I, so I appreciate it. Again, my name is David Nemiroff. I have the privilege and honor of running what's called the Long Island Federally Qualified Health Centers. And we are a cadre of health centers here in Nassau County. Short story, our history goes, we were once Nassau County Department of Health. Nassau County then created the public benefit corporation called Nassau Healthcare Corporation, which encompassed our health centers. And then in 2009, the hospital created the Federally Qualified Health Centers that I have the honor to run. So next slide. And so people said, to answer Kemp's question, we put a little blurb here of what is a Federally Qualified Health Centers. So really they were designed to improve access to primary care for really these low income, what the federal government calls medically underserved areas, census tracts throughout the country. And it's really, as it was, they're about 50 years old, and it was done in a time where there was some high poverty areas. The first one I think was in Massachusetts, and these were designed to service individuals in those communities. Next slide. So this is a busier slide, but this slide kind of talks a little bit about what FQHCs do today. So FQHCs today are located, as I said, in high need areas, federally qualified health centers. They're also, you may have heard the term community health center. Senator Schumer talked about this the other day in terms of giving out at-home test kits to community health centers, which we're going to try to be in line to give for folks. They're open to anybody who lives in the community. And it's funny, the term is federally qualified health centers, yet we never ask about immigration. So most of our uninsured patients are probably, we assume, people who are undocumented. We have a comprehensive set of services. We must provide primary care. To Dr. Markowitz's statement, we must take you regardless of your ability to pay. And we do have here in Nassau County, I share that 25% or 10,000 patients that we serve are uninsured. And their average payment to us is maybe $20. And that's for everything. That's for their whole visit. There's a common set of services we have to do. And the board of directors, you'll find it very interesting, is run by our patients. So 51% of our board of directors are people who use the services. So my board chair is a patient at one of our health centers and tells me anytime he goes, if he has to wait, if he can't get through on the phone, it's very patient-centered, and you're right, you're hearing it. So my boss are all the patients who use it, so you don't get any more connected to care. And the commercial is here. 28 million people are served. There is a health center in every congressional district in the country. I think there's 2.3 million people are served in health centers in New York State alone. So very large network here in this state. Lots of children, unfortunately, lots of homeless, veterans. So we're kind of the safety net of community providers out there. 50% of my patients are on Medicaid. And then 25% are uninsured. So 75% of my patients are either on Medicaid or uninsured, and I think 67% live below the federal poverty level. Next slide. And this is just more data about health centers. This is right off the National Association of Community Health Centers website. So they have some infographics if those folks are interested. You can also, on their website, look to find out where is there a health center in your community. We happen to be here on Long Island. We'll share that in a minute. But we deal with a lot of various things that the 1115 waiver and DSRIP was designed for. So health centers are designed to kind of be this catch-all. And if you, the statement says, if you've seen one health center, you've seen one health center. Everyone is slightly different, but our missions are aligned to really support the underserved. Next slide, because I don't want to spend a lot of time on that. So this is our mission, which is really to provide comprehensive primary care and preventative. So Walter mentioned this. It's been a challenge, Walter, because the fee-for-service kills me. But the hope is we will get to where we're focusing on much more social determinants and preventative care. Next slide, please. Just some very brief services. This is a short commercial just of what we offer here. But we've probably changed thanks to DSRIP and my experience leading the Nassau Queens PPS. We've added a lot of things that focuses on what we call social determinants of health and that are non-traditional healthcare. We've added health home care management. So where we have people out in the world who will go visit you at home. I think if you hit the, there may be a couple of things below that, Tony. WIC, Women's, Infants, and Children's Supplemental Nutrition Program, because without food, it's kind of hard to take care of young ones. And then community health advocates, what we call, those are community health workers who go out into the community to interact with our patients. And COVID, blessing in disguise, helped us to get grants to go to a patient's home. We actually were asked by Nassau County to set up telehealth and remote work for their homeless patients who were living in a shelter. And we would send a community health advocate and a nurse to see that individual and then telehealth them to a provider during COVID. Because they didn't know how to bring them in, they couldn't get them there, so we went to the patients. And it's really getting outside the four walls. Next slide, please. We have 6 main locations serving around 44,000 individuals a year. And then we're in 3 high schools, which is kind of neat and fun. They were shut down forever during COVID, but they're back. So we're in the Freeport High School, the Roosevelt High School, and the Westbury High School, and in negotiations to be in the Baldwin High School. Next slide. This is just a little map of where we are here in Nassau County. So we're throughout the county, and from Elmont to Freeport, Hempstead, Oceanside, Roosevelt, and Westbury, Newcastle area. And just the next one. So I can talk a little bit more. This is a little bit about the income guidelines of our folks. And a majority of our patients are females. And the next slide, and then I'll get to some of the NQP stuff. So just, I want to thank you guys for that. But to speak to Kemp's comments on the Nassau Queens PPS and my experience. One, our agency became a patient-centered medical home due to that. I had the pleasure and honor to work with 3 large health systems, Northwell Health, Catholic Health Services, and Nassau University Medical Center that came together to serve. I think at the one point we had almost 800,000 people that we could serve. And that was a big deal. A lot of that was just challenges were internal dynamics that Joe could probably talk to better, but he's still there as running the PPS, so he's done a better job. But in Nassau, outside of the politics, what I think it did do is it actually created relationships. There was the beginning focus on social determinants of health here. There was an awareness of working with community-based organizations, which you will see in the 1115 waiver. And there was a focus on trying to improve outcomes. The big push there in the first one was to reduce avoidable hospitalizations. And folks may be aware that here in Nassau County, with all of our lovely hospitals, about 70+% of our emergency room visits are avoidable. Now people would even say with COVID, if you're unvaccinated, that's an avoidable hospitalization. But pre-COVID, about 70% of those visits were avoidable. So DSRIP was designed to help bring care to individuals to do what's called population health that Walter and Rachel had spoken about, to help a certain population understand and how to get access to care. It helped us. We grew patients because patients learn more about us, but community-based organizations grew as well and were able to access and support patients. And Northwell and Catholic Health Services and others had more of a connectivity to understand that there are other resources out there. Now, yes, I think there's many flaws with DSRIP 1. A lot of dollars went to hospital systems instead of community-based organizations, but it opened the door. And if DSRIP 2, the 1115 waiver does happen, I am optimistic that we can actually focus on social determinants and actually get some of those dollars where it needs to go, because the amount of money we're talking, whether it's 17 billion or 8.5, is significant dollars that can change a lot when it comes to social determinants of health and improving health outcomes. Nassau County has one of the highest maternal mortality rates in the state when it comes to African American and Hispanic women. That's ridiculous in one of the wealthiest and quote unquote healthiest counties in the country. So there's a lot of work to do. And if this does get approved by the federal government and the way it's designed now, and I love the fact that they looked at folks in prison and they talked about housing. We did actually a small project with United Healthcare where they paid for rental housing for 10 of our chronically ill patients, and they saved millions of dollars just by paying for housing. And that's a healthcare company. So we know that those things work, and it says it in the 1115 waiver white paper. So as we talk more about it, I'm hoping we can get to some improvements in outcomes, better work with community-based organizations that can provide the housing and the food and the jobs and the education that our folks need. Because I joke with folks, but maybe it isn't a joke, that during COVID, I think we gave out as many food kits through Island Harvest as we did COVID shots and COVID tests, and that's not okay. And I've done 27,000 plus vaccinations so far. So I've probably given out almost as much food, and I'm a medical facility, as you just saw. So I am a social worker, hugely optimistic about what the future may bring. District 1 helped, I think, set the stage, got us together, got us thinking, built systems like the Staten Island and other PPSs upstate that are still functioning and working together, which is great. Let's take it to the next level. But I think we have to also be brought together to shape what that looks like. When and if the federal government supports that, it'll need a lot of community involvement at these type of things to move the needle to make sure that the outcomes are what we want and the dollars go where they're needed. So Kemp, thanks for allowing me a few minutes.
Thank you, David. I'm reminded, I'm looking at my notes and I skipped over some of your background, which led to all of those informative comments, such as heading the Mental Health Association of Nassau County, and extensive work with the family residents and essential services dealing with kids. It's that type of actual clinical experience that gives rise to being able to run something like this. And before I introduce Joe Conte of the Staten Island PPS, I just want to say that Nassau's Long Island Federally Qualified Health Centers are only 12 years old. Didn't come about easily. I remember being there working with them because there's very strict requirements that the patients have to be in the majority. It has to be funded. It has to have a relationship. And now you're serving 44,000 people a year. Yeah. And the very fact is that DSRIP 1 was to deter people from going to a hospital and finding care elsewhere. And that's why you're getting some of that population. And so as we move forward, Joe Conte, who has had challenging administrative roles with several of the major hospital systems in the metropolitan area, including Northwell, including the Catholic Health Services of Long Island. I kidded him about at the Richmond University Medical Center. He said that was the easiest. It was only one hospital. But he was appointed to be the head of the Staten Island performing provider services under DSRIP. And I got to know of him because people would keep mentioning that what he had been doing, kept on going to different conferences, and he would be speaking. So it and continues. I don't know how you continue to have the organization still going when the waiver itself technically ended in 2020, but more power to you. And you have a great presentation. Hopefully you'll share it with everybody who's on still with us. Joe.
Thank you, Kemp. Right, and thank you, Anthony, for the work on the slides. And I'd like to thank Dean Sarah, the Honorable Kemp Hannon, and my fellow speakers. I think it's a terrific program, and I appreciate the opportunity to speak to you tonight. Just by frame of reference, the United States has the largest healthcare bill per capita in the world, greater than 2 times the total cost per capita of any industrialized nation. And we have about half of the benefit of the outcomes that any other industrialized nation has as well. An interesting point is we also spend half the amount in social care of any other industrialized industrialized nation. So you may be able to get a little bit of a point of where I'm heading in these comments. So we're going to talk about the Staten Island PPS, about my observations related to DSRIP 1.0, and then what we hope to see in terms of DSRIP 2.0 and what the challenges that might lie ahead. This picture that you see, these are a group, half the group of graduates of a home health aid class that we just sponsored, individuals drawn from the North Shore community of Staten Island, where disparities and a number of social determinants of health are much more manifest. And we provided scholarships to these nice people. And they graduated their home health aid class this past Tuesday, and they already started working in our community. Next. So the Staten Island PPS was formed by Northwell under the guidance of Staten Island University Hospital and Richmond University Medical Center, the two healthcare organizations on Staten Island that provide inpatient care. The beauty of our community of 500,000 is that the community organizations went to the two hospitals when the Department of Health was asking for proposals and said, we want one proposal for Staten Island. We don't want to have a proposal put forth by competing organizations. We know we need to collaborate, we need to cooperate. And so we had that spirit from the very beginning, which was enormously helpful in achieving our work. So as you can see here, all of the major players in the orbit of health and social care were on board when we started our work. And we spent DSRIP year 0, which was a planning year, to create a platform of collaboration and cooperation based upon population health analytics. And we were one of the top performing organizations throughout DSRIP. And at the conclusion of it, earned $62 million in bonus funds. So I can put Kemp's question to rest about how we're still operating. Next. Next slide, Anthony. One of our secret sources, if you will, was the focus on business intelligence. We created, right from the start, a data warehouse and an analytic platform that was able to guide the direction in which we focused the resources that we earned through the DSRIP program. And DSRIP was not a grant. It was a pay-for-performance program where organizations needed to achieve levels of outcomes, of engagement of individuals, and clinical outcomes to earn those funds. And at the conclusion of this program, we earned 120% of what we potentially could have earned by having a great group of providers and having the kind of analytic platform that is displayed here in these slides to rely on. Next. But more important than analytics is understanding the community that you serve, the social drivers of health, or social determinants of health. And I think this graphic really is an insight into how organizations that provide health and social care sometimes perceive the individuals that they serve, when in fact what is really going on in their life is what's driving what is perceived as non-compliance or non-adherence. And really an important focus about how the DSRIP 1.0 was heading and where DSRIP 2.0 will hopefully land us. Next. So our organization is still thriving in the post-DSRIP period, as what Dean Sarah mentioned. March 30th of last year was the conclusion of the DSRIP program. But Northwell Health, who was our sole parent and operates our organization now, believed that the work we were doing was important, needed to continue. And I couldn't have agreed more. And I don't think the providers or the population of Staten Island could have agreed more as well. So this is a quick snapshot of the things that we continue to focus on. Certainly, with the report that came out from the CDC last week, about 100,000 opioid deaths in the United States. This is a main driver, but we have continued to focus on social determinants of health, population health, importantly, health equity and addressing disparities as an underlying cause of the population concerns that we have. And we continue to drive forward with workforce training and employment to address many of those factors that I just mentioned. And of course, COVID continues to be an area where we have a great deal of emphasis and have worked very closely with our colleges, our FQHCs, and so many partners to address those concerns. Next. Thank you, Anthony. So this is going to be a couple of comments about DSRIP 1.0, a view from the rearview mirror. Next. So what can you buy for $6.2 billion? Some people would say quite a bit. In retrospect, I think while we made a lot of forward movement in terms of understanding where we needed to head, the sustainability that was supposed to be one of the underlying factors in DSRIP was something that we did not achieve. And I think these bullets here are reasons why that was not the case. And perhaps first and foremost is that there is an enormous conflict between capital investments of the past in bricks and mortar and a move to value. In DSRIP, some of the successes that we achieved, a 26% reduction in preventable admissions, an 18% reduction in preventable readmissions, so many of the other HEDIS measures that really moved precipitously to the positive. New York was 45th in overall HEDIS measure performance at the start of DSRIP in 2015, and we moved up 30 places during the DSRIP era. And the cost per member of Medicaid beneficiary in 2019 actually was driven down to the 2011 levels. This is a significant achievement for 6.4 million covered lives. In the organization of healthcare in as complex a state as New York, where we have rural, urban, and so many areas in between for care to be provided to achieve those outcomes was substantial. And I think it really has given CMS a cause to reflect favorably on what has been submitted for a DSRIP 2.0. But there continues to be many structural components that are of concern. The first bullet I spoke about, we know also that the social determinants of health were underfunded during DSRIP, and the community-based organizations were not capitalized on in many respects because of structural requirements that spending could only be advanced in a level of 5% to their work, when in fact it should have been one of those areas where 25% of work resources should have been applied. My particular favorite group to pick on is the managed care plans. And I think their relationships with the providers are really still organized in a win-lose proposition. And they really were winners during DSRIP. The work that was done on behalf of the community and the beneficiaries of Medicaid benefited them financially with the reductions in cost, reductions in admissions, preventable readmissions, and the like. Their cost of care was driven down significantly, and they contributed minimal amounts other than a cheering section for us to do our work. Another barrier is the analytics necessary for delivering value really are beyond most organizations' scope and breadth and resources. And the partnerships that were necessary to overcome barriers between providers, plans, community-based organization, local governmental units did not materialize for all of the reasons that I just spoke about. So we are starting what we hope will be DSRIP 2 with some areas that really still need to be addressed if we're going to be successful. Next, please. So DSRIP 2.0, a cautionary tale, the question mark is in parentheses, and the subtitle is Bureaucracy is the Wasteland Where Dreams Die. Next. And I say that the bureaucracy is the wasteland where dreams die because the first 10 pages of the conceptual document left me speechless about the complexity of the proposed infrastructure that would be required to plan and implement a DSRIP 2.0. One can only hope that clearer minds will prevail and we will be able to streamline what looks like, to me, a bureaucratic nightmare, which will prevent any goals from being achieved. But let's move on to the more positive focus. The idea of redesigning health and behavioral health systems and effectively integrating social care and healthcare is certainly prominently spoken about. I think one thing that I would like to point out is that we shouldn't be talking about health and behavioral health anymore. We should be talking about healthcare. We continue to separate health and behavioral health as if they're two monolithic and independent areas, when in fact they really are one. The idea, of course, in DSRIP 2.0 about addressing disparities and promoting health equity and creating measures to ensure that when we focus and apply resources, those things are achieved, I couldn't agree more with. The idea of a centralized data collection and exchange within the statewide digital health and telehealth infrastructure, again, absolutely required. The Department of Health has already invested over $1 billion in RIOs throughout New York State, and it's about time that those organizations began to pay dividends to the people whose taxes have gone into creating them. Supportive housing solutions, certainly an underpinning of any real meaningful change in healthcare. Advanced VBP models with rewards for the organizations that participate in them, not a win-lose type, but a win-win model, and developing a strong, well-trained workforce. These are absolute priorities if we are going to achieve the kind of goals that DSRIP 2.0 has put forward. Next. And a review of the barriers from DSRIP 1.0 versus the context of 2.0. So much of what I have just spoken about, we still have challenges in achieving. The idea of the past capital investments in bricks and mortar and a move to value, which will reduce admissions to the hospital, ER utilization, and ultimately, should we achieve the goals that David referred to earlier about a true population health model where wellness will replace this sick care system that we have, will mean reduce revenue. This is a challenge. The social determinants of health that were underfunded and community-based organizations marginalized, the DSRIP 2.0 proposal, much better by far than 1.0. The managed care organization relationships, conceptually, I think what I have read is okay, but is not likely as described to be implemented. And I think the plans really do need to be put on the spot in a much more significant way. They need to be part of the crew team that is going to row this show to victory. And right now, I don't see it. Analytics are necessary for delivering value proposition and targeting initiatives. We really have many promising concepts in 2.0, but there are also many questions. and the partnerships necessary to overcome the barriers between the providers' plans and the rest of the participants, there is still a huge challenge here. There is a real power gradient that is palpable in healthcare, and it creates imbalances between large health systems, the FQHCs, small primary care providers, the community-based and social partners that do this work. And this really is something that needs to be addressed if we are going to achieve the paradigm shift necessary to move from a sick care system to a well care system. Next. So you could read this for yourself, but it's clear if we keep doing what we've been doing, we'll get what we've always gotten, an expensive, high-tech, inefficient healthcare system. The healthcare system needs to be redesigned. This is clear. And, my closing thoughts, we need to reorient to a well care system, not a sick care system. We need to be culturally competent, high impact, low cost. And we need to focus on health equity, maximize cooperation and services, leverage partner strengths, powerful analytics and free data exchange. We need to reward the workforce so there is joy in their work and patient experience. It's really simple. And the next slide is what's going to happen if we don't do this. Thank you for the opportunity to speak to you tonight.
Thank you, Joseph. Really appreciate it. There is a whole host of questions. There's a whole host of points. First of all, I would want to stress to folks who are interested in this whole topic that the background material I've provided with this, I think is essential. There is a live reference to the link to the actual conceptual application. There are URLs for the other studies that were done of DSRIP 1, although there is the URL for the most comprehensive summary of DSRIP 1, a study that was done by SUNY Albany, no longer leads to a live link. I know that it was there. I have a copy of the link. Anyone who wants it, a copy of the study. I have a copy. It's 500 pages. I downloaded it just to prove that it exists. But more importantly, the more you can spend reading the actual conceptual application, the better off you'll be. To get some idea of what's driving this and where we're going. One thing that struck me, because people will take the improvements in health that are discussed as, oh, we're just trying to be some type of social reformers. And the point that I think rebuts that the best was the conceptual application talks about access for the criminally justice involved populations. And why would you do that? It says that 83% of those incarcerated are in need of treatment for substance use abuse upon release. 83%. And then it also talks about the share of individuals in New York City jails who have mental illness, and that percentage has reached 40% in recent years. So in other words, we're going to have these individuals as part of the healthcare system, no matter what we want to do, because that's what we will do, is take care of them. And the best way to do that will be get before they present. So, and that flows through the rest of the populations that need to be addressed. But I just want to think aside from, and Joe, you brought this up about the bureaucracy. And the bureaucracy is going to be very difficult, which is evident as you read about organizations for the social determinant of health and organizations called the heroes. But I'm wondering, before you get to even sorting out those organizations, how one continues to deliver healthcare to all the folks who are going to currently present to a hospital or a clinic or a physician with real needs, broken bones, heart attacks, whatever else. but how do you take care of them while at the same time you're building a new system? David, Walter, Renee, Joe, what are your thoughts?
Wants to go.
Who's first?
So I will say, I think the bigger question is getting into the communities because people can't make it to the hospitals. We saw during COVID, we were overburdened in the hospitals by the number of care. So you're right. How do we take care of the heart attack, but how do we take care of the long hauler COVID syndrome and still respond to this pandemic? And what I'm really thrilled about us talking about in this new expansion is that we are going into the communities, because that is what has saved us in this pandemic. Getting to the faith-based leaders, getting to people who are afraid to leave their home, getting to people who can't leave their home, and bringing care to where the patient is rather than the patient having to come to us. So David, I don't know what you think about that.
Oh, I agree 100%. And Kemp, I don't think you touched on it, and it won't fix the broken leg, but telehealth has kind of changed the dynamic a little bit for us. So it has created new ones, but I think we've done like 40 or 50,000 telehealth visits in the pandemic, and we kind of we were allowed to do it, but we just weren't paid for it before. So now systems and people figured out how to connect to people via these new devices that they didn't really use for going to a doctor. So that's helped a little bit. It doesn't fix the broken leg. It won't fix going to the OB, but it's just a tool in the toolbox. And as you know, Renee had said, we have to be in the community. And I think what's going to happen is, and I'm hopeful going to happen is, these larger systems have seen that they got inundated in the hospitals, and a small investment in communities, as they say, upstream, should help relieve some of that pressure. But this is, you know, again, decades, if not centuries, of racial profiling, redlining. You know, I'm in Roosevelt in this little mile square area, and the per capita COVID cases were out of control compared to the rest of, you know, Nassau County. So there's things have to change. There's not a Whole Foods in our community. There's not great, you know, grocery stores for folks to get healthy food. And the income inequality is huge from, as you know, Senator, from the Hempstead Village and Roosevelt versus a Garden City, which is on the other side of the train tracks. So what I think has to happen is a small investment. We have to keep going with the community providers and support them along the way while we look to these other things. And I think there's some lessons learned from Joe and others that can help us. So maybe we don't make some of the same mistakes, but I loved his comment about the bureaucracy. I'm fearful that big systems will come in, and I apologize for those Northwell folks, that will come in and kind of say, okay, I got it, and we'll let you know how it works out. And that is a fear of mine as a smaller provider, because they have much more capacity. But maybe the better investments is really pushing, as Joe had said, not 5%, not even 25%, or maybe 50% of the dollars down to where it's needed. You know, I love the housing piece in here, but that's going to take years. That is not something you just, you know, materialize out of thin air. And we know when we house people and they're not in homeless shelters, they get better. And if we just invested as a country, we'd have better health outcomes if we just had better housing. So it's not, there's no silver bullet, Kemp, to figure out how do you do this. But District 1, we definitely were building the plane while flying it. Here, we've learned a little bit more. So maybe we've, you know, kind of got to a destination, and now we have to do a little bit of work, and then we can take off again. But I think this COVID actually helped in the sense of jumpstarting some of the racial disparities, health inequalities, and some innovative practices that we didn't have before. So we are a leg up from where we were before in that regard.
I was kind of thinking about how the extent to which we've gone backwards in some ways by de-investing in things like safety net hospitals, safety net facilities, and also by de-investing in facilities that are located in rural areas. We haven't really solved the problem of maldistribution of medical and clinical manpower, where there are areas that are in desperate need of community-based services. And we haven't solved that. And it kind of goes along with how is it that we're really going to develop a system in which we get appropriate manpower, not just physicians. Obviously, Renee and nurse practitioners are doing some wonderful things in filling in for pieces of this, but there are just some tremendous gaps in areas that are of tremendous healthcare need right now that are frankly not being served. And you know, the closure of so many of the rural hospitals and the safety net hospitals is something that has been almost catastrophic for so many different communities. And how to turn that around, you know, perhaps some of this money can be used to help in that direction. I don't know how the rest of you feel about that.
And I think Joe is doing this, right? What we're really talking about, and we're not saying the words, is trust.
Uh-huh.
So, you know, the community-based organization, what Joe is doing by creating a safe place where it's just not about illness, but it's about how do we get you employed, and it's about listening to what the community wants and about integrating health so that you don't have the stigma of I've got diabetes, or the stigma that I've got, you know, behavioral health issues, or the stigma that I'm an abuser is important. So Joe, I don't know how you respond.
Well, I would say, you know, a comment that we use all the time, and I'm surprised it's not in this deck tonight, is progress moves at the speed of trust. You know, and this is really true. The organizations like FQHCs and small private practices, social and faith-based organizations are better at creating trusting relationships with people. And as Kemp also pointed out, in contrast, those are not places to go if you're having a stroke, heart attack, or you know, you've been in a motor vehicle accident. But we do need a rebalancing so that these trusting relationships can be utilized to engage individuals, their lifestyle choices and behaviors that are so complicated to address because of cultural differences and backgrounds are enormously important. We're working on a project now, it's with 5 cities around the country, called Take the Pressure Off with the American Heart Association, and to go into Black-owned barbershops, because Black men in the United States have a stroke risk about 4 times higher than a white male, and their mortality is similar to that. And we're not doing it in FQHCs, we're not doing it in hospitals, we're not doing it in clinics, we're going to barbershops, because that's where people have trusting relationships. That's where they can, you know, no pun intended, let their hair down and have a conversation with somebody and talk to a community health worker and, you know, gradually try to, you know, get that mobile health unit outside and, you know, talk to them about ways to take the next step and, you know, have a nutritionist stop by and do some online teaching about food preparation with their significant others and families. And so, you know, these are the ways to make change.
I
just wanted to point out that in the waiver, there are 2 terrific pieces under goal number 4. And there's only 4 goals, even though the first one about changing everything takes up more than half of the paper. But the 4th goal is about telehealth and digital health. And they are terrific pieces. They could be done alone. And actually the telehealth piece, I think, answers lots of the questions we all have. I want to change the subject a little bit because I want to take advantage of all of your thoughtful comments and your perspective on healthcare. One of the things I had wanted to do as part of this forum was to talk about behavioral health, but I wasn't able to really think out how we could shape that conversation, who we could get to shape that conversation, the direction we would take for it. And part of the waiver talks meaningfully about addressing behavioral health, but I'm thought about how do we address it in the future, in the next forum. And we may have, this waiver may give us several forums, but how do we address behavioral health as the next step that needs discussion, illumination, and then action?
So I was going to say, and looking at Dean Seraph, this is a workforce issue, and behavioral health really demonstrates that. So I was lucky to actually collaborate with Dr. Nemiroff on something that we were going to do in terms of a grant, a national grant. And it was really to integrate primary care into behavioral areas. And we were going to do it with a population that really was uninsured and was working. And I think that that's another piece that we keep forgetting about, and nationally we keep forgetting about. We think that the Medicaid demonstration projects affect patients that really are unemployed. That is not true. More than 70% of the people that we see in FQHCs are employed, but they are the working poor.
Mhm.
And the issue is, who is the workforce that is going to come to take care of them? So, you know, the work that is done in this school under the direction of Dean Syrup, and then also definitely the work that's done under the direction of Dean Gallo, is how do we get community health workers, social workers, health professionals, nurses to understand the technology that we can utilize, and to understand and be well-versed in recognition of behavioral health issues. Because my patients had to wait sometimes 11 months to get to a psychiatrist, 9 months to get to a psychiatric mental health nurse practitioner, but only 3 weeks to get to a community health worker or to a social worker. So we really need to work better at integration and being interprofessional and educating all of the individuals that are in this healthcare arena to recognize.
And if I may, Kemp, we have been screening for mental health and social determinants of health for years. I was just looking at a report today, 33,000 of our patients, again, have said that they have a social determinant of health issue, but the main one is stress and safety. Those are 1 and 2. It used to be food and insurance.
Right.
And food is like 3, and transportation is 4. But you know, our work with Hofstra, with other providers, telehealth is we're gonna pilot a project with National University Medical Center where some of their psychiatric residents will work with us to do telehealth for psychiatry for some of our patients who can't, you know, wait the 9 months to get into a psych nurse practitioner. So hopefully we can improve some things. So mental health has kind of exploded as a need, which was always there. And I think John Javis from one of the behavioral health IPAs is on as well. But I like that it's predominant in the waiver concept paper. I like that it's conversation about bringing it together. Unless the insurance systems change, it's still going to be a battle. That's something FQHCs have been fighting for years, that things should be included more so. And some have done so with Article 31s and Article 28, mental health and primary care. But we do have to go into the community. Renee's right. Big focus on community health workers to build that beginning relationship. So then people are willing to go to see a mental health practitioner. And then there's, as you said, workforce. It's a challenge. Every system right now, Northwell, ours, all the larger systems are struggling with employees, right? We've had the most openings ever in my 8 years here, because people are done, they're burnt, and they don't want to be in healthcare. So yes, we're doing psychiatric telehealth and behavioral health work remotely, which is great, but it's been a very, very challenging time to hire clinicians and even community health workers in this current environment. So it's going to take some work.
Thank you. Thank you very much. As we get closer to the end of our time, I wanted to ask each of you to do a 1-minute summary, a 1-minute criticism, a 1-minute what we should do next. I'll start off where we started before. Professor Markowitz.
I was thinking along the lines of Joe Conte, which basically said that we shouldn't let bureaucracy get in the way of caring for our patients. And I think that the flip side is really what Renee and also David said. I think that we have to get away from the idea of the big monolithic networks and instead bring the care down to the community level and hear from the people in the community as to what their care needs are, and then make every attempt that we can to try to meet them. And by doing so, we will eliminate a good chunk of the preventable admissions and also the preventable ER use.
Professor McLeod?
So I am going to take a little homage to what Dr. Markowitz said, and I can't believe it because he's my favorite person in the world. If we really realize the importance of community, but the importance of motivating and empowering. And unfortunately, the small individual, non-integrated healthcare response cannot work. So as my favorite person in the world taught me, one healthcare system for all. And in order for this to work, this is going to take tremendous integration. And so I was never prepared more to work in the monolith, but by an organization called the Puerto Rican Organization for Motivating and Empowering Substance Abusers, PROMESA. It met the promise, but the promise that they gave was the 2 federally qualified health centers that I worked for, but also an integrated response that was home care, employment, and long-term care. We didn't speak tonight about long-term care, but we've got to be in this for the long haul. And that's the elderly population as well. And unfortunately, people my age that were affected by COVID that are experiencing the needs of needing long-term care. So I think we're going to have to integrate, motivate, empower, and integrate, and hopefully with health equity.
Thank you. David Nemiroff?
Well, Renee, great job. She stole my thunder. Mic drop after her comments, but I'm fortunate enough to be a social worker and somebody who leads an organization kind of dedicated to helping those folks, regardless of anything. If they need it, they'll walk through the door. They're here for us. I'm on a board, the Health and Welfare Council of Long Island. I hope they play a larger role. They are a consortium of nonprofits, that community-based organizations that should take a lead role in the HERO and in the social determinant of health network. Because I still think a small investment, and small meaning state standards, just a chunk, maybe 50% of this, would move the needle much more so than a large investment in big systems. And I will admit to you, I'm a closet admitter here, I have a relationship with National University Medical Center. We try to have conversations with Northwell and they go work out pretty well. They have capacities we don't have. So there is a need for these larger systems that have more complex care that they can provide than we could ever do. And we can't do it alone. So let's not put us against, we just have to do it with and invest dollars the right way that'll have the largest impact. And hopefully we don't have the bureaucratic mess that Joe's talking about, writing these papers and checking boxes for 2 years that I was there doing DSRIP was not helping anybody get better health outcomes. So in DSRIP 2.0, let's push and advocate and demand that resources go as quickly and as efficiently and as effectively as possible to where they're needed. And let's use RIOs and other things that are already built to make it a lot less onerous. Because I joke that we should have just asked Google to design some database, because if you break your leg in Long Island, you break your leg in the Finger Lakes, it's still a broken leg. We don't need 25 different EMRs. We just need one place to do that. And the state could probably do it for pennies on the dollar compared to what I could do. So my hope is we keep moving forward. The feds do hopefully support this and we get to shape the future, because the next 5 years could turn into the next 10 and the next 20. So that's my talk.
Thank you, David. And Joseph Conte, didn't mean to have this happen, but you basically get the last word.
Wow. Well, I owe you a Heineken, Kemp. I think, as I hear what everyone has said, part of me is tempted to say what they said, but I'm going to say something else. And first is healthcare needs to move away from the edifice complex. We have too much capital investment in buildings and the kinds of technology that are only created for competition, not for quality. I think we need to refocus on health equity in a way that we have only given lip service to up until this point in time. We need to move to a well care system. We really do have an organization nationwide that is designed to treat illness and be heroic, and we do it amazingly well, better than anybody else in the world. But at the same time, we have the lowest life expectancy of any industrialized nation. We have the worst outcomes for childbirth. We have terrible outcomes for cardiology, diabetes, hypertension, and asthma. And this just does not make sense at all. We absolutely need payment reform, because without payment reform, all of the things that I just mentioned will not change.
That's right.
And in final statement, the workforce needs to get the kind of attention that it has not gotten up until now. If people don't have joy in their work, if people can't wait to get to work to do their job, it's just like any other profession, and that is not what healthcare is supposed to be about. Thank you so much for the opportunity again.
Thank you. And thank you to all for participating in your very, very thoughtful comments. Thanks to Hofstra, thanks to Dean Porcelli, thanks to Dean Syrup. This webcast has been recorded. It'll be up on the site in a couple of days. And I hopefully that we will be able to come back together again at some point as the actual application goes through. In the meantime, on the background material, at the very last citation is a citation to a very recent federal component part of CMS and their thoughts as to where they're going conceptually with healthcare. It gives you a lot of insight as to how the state's application to the federal government may be treated. With that, I thank everybody for being with us, for the large number of people who have stayed with us throughout the entire presentation. Have a good evening.